Weaning Protocol by Morgan Chera, Randy Rourke, Samantha Rotz, Shelby Carmine, and Taylor Reggett. Caring for a patient on a ventilator. There are many different interprofessionals that care for a patient on a ventilator. In this presentation, we will discuss in details the duties of the nursing staff and respiratory therapy when caring for a patient on a ventilator.
Respiratory therapy. Ventilator settings should be the following. The mode should be in assist control, tidal volume 6 to 8 milliliters per kilogram, FiO2 at 100%, respiratory rate at 12, PEEP at 5 centimeters, pressure support at 10 centimeters H2O, and you should monitor the oxygen sat via continuous pulse oximetry, and you should change the probe sites every shift. Monitor ABGs after 30 minutes on the vent and contact the physician with results. Keep the O2 sat at or above 92% or as per physician order. Notify physician if O2 sat less than 92% on FiO2 of 100%. Respiratory therapy continued. After ABG, if pulse ox equal to or greater than 92% or per physician order, and PaO2 greater than 100, decrease FiO2 by 10% every 30 minutes to keep 40%. Keep O2 sat greater than 92%. Albuterol nebulizer 2.5 milligrams per 3 milliliters in inhalation every 4 hours PRN. Secure tube and initiate end-tidal CO2 monitoring by placing end-tidal CO2 sensor in line with the ventilator circuit. Obtain baseline sputum culture.
Nursing considerations. Insert OG tube, Salem sump to low intermittent suction. Elevate head of bed 30 to 45 degrees, 45 degrees is preferred, at all times unless contraindicated. Initiate mouth care protocol, oral care every 2 hours. Enter respiratory care order for mechanical ventilator and note weaning protocol in the comment section. Diagnostic studies. Obtain stat chest x-ray to confirm endotracheal tube position and notify physician if of normal findings. Pulmonary embolism, deep vein thrombosis. When a patient is on a ventilator, they are usually sedated and are unable to move around in the bed. When a patient lays still for long periods of time, they run the risk of developing a DVT or a PE. A pulmonary embolism usually happens when a blood clot called a deep vein thrombosis, often in your leg, travels to your lungs and blocks a blood vessel.
If you are immobile for an extended period of time because of surgery, pregnancy, illness, or travel, you may be at risk for deep vein thrombosis, or DVT, a condition where a blood clot forms in a deep vein in the body, typically the leg. Unlike arteries, which rely on the heart to force blood through them, veins transport blood with the help of muscle contractions while you move and walk. Veins also have valves that keep blood from flowing backward and pooling in your arms and legs. When you are immobile for an extended period, your venous circulation slows down. As a result, clotting factors in the blood may cause the slow-moving blood to clump together, forming a blood clot or thrombus. This condition is called deep vein thrombosis, or DVT. Common symptoms of DVT include swelling of the leg or a vein in the leg, pain or tenderness in the area, increased warmth in the skin, and red or discolored skin. In some DVT cases, a blood clot may detach from a deep vein and join the bloodstream. The clot travels from the deep veins of the leg, through the veins of the abdomen, into the heart, and finally lodges in the pulmonary artery or its branches, blocking blood flow to the lungs. This condition, called pulmonary embolism, is very serious and may permanently damage a portion of the lung. If a clot is large, or if there are many clots, pulmonary embolism may also cause death. If you experience symptoms of PE, please tell your doctor or nurse immediately. These symptoms may include shortness of breath, a sudden sharp pain in the chest, a feeling of lightheadedness or dizziness, rapid or irregular heartbeat, or coughing that produces blood. To help prevent deep vein thrombosis and pulmonary embolism, your doctor may require you to do the following. Walk around periodically to keep the blood from pooling in your legs. Wear compression stockings, and take anti-clotting medication.
Prophylaxis for pulmonary embolism, deep vein thrombosis. Lovenox 40 milligrams subcutaneous daily, or Lovenox 30 milligrams subcutaneous daily if creatinine clearance is less than 30 mLs per minute. You also put on sequential compression devices up to the thighs. Exclusion criteria is active bleeding, hypersensitivity to UHF or LMWH, heparin-induced thrombocytopenia, uncontrolled hypertension, coagulopathy, intraocular or intracranial surgery in the past 6 weeks, or a spinal tap or epidural in the last 24 hours. Prophylaxis for stress ulcerations. Patients who are on ventilators can develop stress ulcers from being intubated. To prevent stress ulcers, give the patient Pepsid 20 milligrams IV BID.
So for the labs, anytime on a ventilator, the physician will order an ABD, and the normal values are the pH is 7.5745, CO2 is 35 to 45, CO2 is 80 to 100, HCO3 is 22 to 26, and the O2 sat is 95 to 100%. For nutrition, if a patient is intubated for longer than 24 hours, you obtain a food and nutrition service consult, anchor the feeding tube, initiate enteral feeding, standing orders.
Notify the physician if a patient has persistent distress, respiratory rate greater than 30 per minute, persistently low O2 stat less than 90%, persistent high peak pressure greater than 50, a heart rate greater than 120, and blood pressure less than 90 systolic or greater than 160 diastolic. Daily assessment for readiness to wean from the ventilator. The daily respiratory therapy and RN will assess the following parameters to determine readiness to wean from ventilator at 6:30 a.m. or shift change. Begin weaning once patient meets the following parameters. Underlying condition resolved or improving, PaO2 or FiO2 ratio greater than 200, FiO2 0.5 or less, PEEP less than or equal to 5 centimeters H2O, hemodynamically stable, no significant arrhythmias, or systolic blood pressure 90 to 180, dopamine, debutamine less than or equal to 5 micrograms per kilogram per minute, or no vasopressor therapy.
So this is daily assessment for readiness to wean from ventilator therapy. Patient oxidation is awake, comfortable, and follows commands. They can lift the head off the pillow. They have rapid, shallow breathing index less than 100. The respiratory rate is less than 35 breaths per minute. The heart rate is 60 to 20. They have spontaneous VT. It is 5 to 7 cc's per kilogram of ideal body weight. Lab results, the pH is greater than or equal to 7.35, hemoglobin greater than or equal to 7, and the potassium is greater than or equal to 3, and phosphorus is greater than or equal to 2.0. So this is spontaneous trial weaning. Once a patient meets all the guidelines, the spontaneous breathing trial may begin. You place a ventilator on spontaneous mode for these settings. The same FiO2, the PEEP should be 5 centimeters H2O, and the pressure support 10 centimeters H2O. And the trial should last between 30 minutes and up to 120 minutes.
Spontaneous trial weaning continued. Once patient tolerates the breathing trial, obtain an ABG, obtain weaning parameters. Call physician with results of ABG and weaning parameters. Stop weaning and place back on previous ventilator settings if respiratory rate is greater than 35 per minute or less than 6 per minute, heart rate greater than 140 beats per minute or 20% increase over baseline, SpO2 less than 90%, tidal volume less than 5 milliliters per kilogram or less than 300 milliliters, greater than 50% FiO2 to maintain SpO2, respiratory distress, diaphoresis, agitation, and anxiety, BP less than 90 or greater than 180.
Extubation. Call physician to report parameters, ABGs, and obtain order for extubation. Once order is verified, extubate patient and replace with nasal cannula and maintain an SpO2 greater than 92% or specific guidelines set by physician. Monitor SpO2 regularly and obtain ABGs if the patient is in respiratory distress. Apply BiPAP via ventilator circuit if post-extubation respiratory difficulty is expected to occur. For post-extubation stridor, administer racemephrine 2.25% inhalation solution 0.5 ml nebulizer, 1 dose, and notify physician. BiPAP used for post-extubation respiratory difficulty. EVP oral care to prevent ventilator-associated pneumonia, also known as VAP. 75% of hospital-acquired pneumonia is derived from ventilators and inhalation of oropharyngeal bacteria, so an oral care protocol is important to follow. VAP is reduced by 50% when proper oral care is provided. The care should include keeping the head of bed no lower than 30 degrees, performing oral care every 2 hours using foam swabs connected to suction and soaked in peroxide-based solution, chlorhexidine twice per day, and ending with the application of a moisturizing gel to the gums and lips. And here are references